So I'll be talking today about something that's very near and dear not only to my work, but to my purpose in life, what I deem as my purpose in life, and that's health disparities and creating health equity. So I'll be speaking from frameworks that I've developed for my aging and Alzheimer's disease and related dementias research over the past 10 years or so. Next slide. So to formally start, I would like to acknowledge several groups of people, entities, especially all the caregivers, loved ones, family in here, who are engaged with research, care, beyond. Without y'all, it's just impossible. Also thank my good friend Dan Billingsley. So the GFPD leadership here, as well as my fellow panelists, and also the National Institute on Aging and the Alzheimer's Association that fund my work, and my friends and colleagues back at the ranch in Chicago at the Rush Alzheimer's Disease Center. So a little bit about me, so you can know where I'm coming from, is I'm an applied social psychologist and mixed methodologist. So that means my whole life is spent around understanding diverse participant perspectives, really how people think about themselves, others, and the institutions in which they reside, particularly our healthcare institutions. And I do that through a mix of qualitative, quantitative, and survey methodologies. But at the heart of it is how to create equity for all persons across the lifespan so that we may be able to have optimal health. So today I would like to take you through a brief journey of 3 blanket topics. First, we'll start out with what is health and how it is constructed. Then we'll discuss differences between disparities and equity, since there are differences there. But then go into re-envisioning research. How through these 5 principles that I will outline from my grant-funded work, that we can really center diverse participant perspectives and their lived experiences. So I always start off with defining health, because I also find in many audiences, even at home with my Alzheimer's disease and related dementias work, we tend to think of physical health as really the barometer of health, and we know that the World Health Organization has expanded it to say physical health, emotional, psychological. But in my work, the frameworks that I publish on, I include 6 different dimensions of health. Of course, physical, so that's without saying. When I refer to emotional, I'm thinking of psychological, as well as emotional and mental. Those differentiations are huge as we're thinking about the quality or aspect of the brain itself in terms of emotion regulation, also mental health in terms of chemistry and other biochemical elements, but also the brain behavior type interaction that I focus on most in my work. How do they talk together and create each other's lives? Okay? Then one that's really big and coming to fore, Dan spoke about it, is huge in my work, is the social environment. What I've found in my work is that who we see, not only in our homes, but in our neighborhoods, where we work, where we go to school, and especially where we get our health care, really feed into our overarching health. So that means if we are in social environments where our interactions are not positive, or they are negative, if they may be productive or accomplishing, if you feel like they are trusting and respectful, they have different elements or different aspects onto your health. But also, these different interactions take place within a built environment, your actual environment. So we have to think about sidewalks, quality of air, green space. Can you get to where you need to go? Can you get there without violence and noise? But 2 pieces that I really have been enjoying working on, even more on the healthy aging spectrum, is intellectual and spiritual health. So intellectual is how we spend our time. So do we feel like we're spending our time wisely, usefully, and really speaking to our purpose? But then that connects to spiritual. That could be anything from belief in a higher power to your own purpose in life. But as I tell my father, it's really how I feel about myself once I lay my head down at night. Without total health in these 6 areas, we would not indicate someone as being healthy. And these things are very much in interaction with one another, as well as constantly changing. So these aspects of health take place in various settings of health. So nothing is experienced in a silo. Of course, at the innermost circle, we have intrapersonal. Of course, that's yourself, that's your genetic code, that's your biology, that's also the behaviors that you choose to engage in. But also, that really comes into play in interpersonal relationships. Are you around people that may may say encourage you to eat better or go for a walk, maybe proceed into your career or take part in your health, those all things in your home and beyond really build into a setting of health. These things are also institutional. So meaning that all of our relationships are in what I call the big five: housing, employment, education, healthcare, and neighborhood. So we're interacting with folks, we're going about our daily lives. These things are in communities, which are very much built environments. Some communities have more resources than others, more accessible to others, have better health care than others, but also have people that may be more respecting of you than others. This is all in a systemic type atmosphere, and that's the macro. So really, it's micro, meso, macro. But the systems here is what I call the shadow boxer. And so I haven't put that in any of my official publications, but that's how I talk about it. If you join me to the left, you will see that a lot of our systems, a lot of our healthcare, our actual interactions are being informed by three big sets of policies. That's macroeconomic, social, and public. So I really would like to focus on social. Social here is really who has access to particular swatches of land, housing on that land, and resources on that land. These codes and policies are both written and unwritten. But this is really married to our public policies. This is how we educate our public, how we treat our public in terms of health, also access to, say, food, water, etc. All of those things are informed by our culture and societal values. Those are things written and unwritten of who do we value. If we think about who are valued in our society, we will really go no further than to the right, in the middle, on the big hits. That is race, ethnicity, gender, as well as socioeconomic status. Socioeconomic status is just not how much money you make, also your education and your occupation. And those things are in interaction with each other to create what we call the social atmosphere. So we can't have the things all the way to the left, the structural determinants, without the social determinants and vice versa. So I've been a big critic, and also in my work at publications and my funding grants, on why are we only focusing on social determinants? So individual behaviors or group behaviors, when we know that these things are informed by the structures to your left. So how can I say, go for a run in the evening if I may not feel safe in my neighborhood, or the sidewalks are not, they're patchy or crumbling, as well as the lighting. So we have to think about the structures in place, the interplay between structural and social determinants, because ultimately, all the way to the right, it enacts equity in our health and well-being. So all of those things together really create what we term health disparities. So by Webster's dictionary, simply an imbalance. But here, what I'm referring to, as well as the CDC in our work, is that health disparities are largely preventative differences, not only in the burden of disease and injury, but really in violence as well. And what I focus on is opportunities for optimal health. So if you're not in an environment, a community, or institutions that are supporting the 6 dimensions of health where you have optimally, that is a health disparity. Okay? These are likely to be experienced by socially disadvantaged groups, minoritized communities that you may think of, racial groups, ethnic, immigration status, LGBTQIA plus communities, etc., that we may think about. I have a chart coming up, a theoretical framework that we've worked on. When I say we, I mean myself and my colleagues, and published on quite a bit. But this exists across all age groups and is highly intersectional. What I mean by that is that you can't simply take a racial group and be able to say that all of those individuals have the same treatment, the same health status as a group. You have to think about these different categories in interaction or intersection with each other. So when we talk about health disparities, we always maybe think about, okay, well, it's just differences between Blacks and whites or Latinos and other groups, but really it's the differences in structural and social determinants of health. Simply because you may know a group member of a disadvantaged group that may enjoy a particular type of privilege or high education does not mean these things do not exist. We're talking about group-based differences here. So if you see differences in structural and social determinants, That is a category of health disparities. That leads directly into a separate categorization, which is being able to access, being able to have, and having outcomes of healthcare that are optimal. But the two others, especially the one at the bottom, is where I spend a lot of my life dealing, is that we see a disparities in the treatment of disease states. So I work with neurological disorders, Alzheimer's disease related dementias, highly stigmatized, stressful, and really almost ghostly, meaning that not a lot of people like to talk about it, and not a lot is known. So the way that we may treat talking about Alzheimer's and related dementias is marked different than cardiovascular disease or type 2 diabetes. And that is what I conjecture as being a disparities, also in the funding world as well. So it's my belief and my work that health disparities are not an anomaly. There's something that really is existent, is the state of our health, healthcare, and even more importantly to me, our research. So this is the framework that my colleagues and I built over the past, I think, well, now is coming upon 7 years now. We really wanted to say, well, this is from the National Institute on Aging, where I have most of my funding, to think, how does this look across the life course? You certainly don't get to a particular age or a different point in life and think to yourself, well, I'm having health issues. These things are occurring across the life course, but also in utero. So we developed 4 big areas that we can think of that really match that micro, meso, macro that I have here. So that is, of course, biological. We have those that represent community and interpersonal, but also environmental, which would be systemic. And then we chose to say, how statistically are these things interacting together? Qualitatively, what does it look like in terms of lived experiences? And how do we enact clinical trials to be able to have interventions and other pharmacologic discoveries that can be able to create a better, more equitable future, particularly for the priority groups that you see to the right. Those are the groups that we see with the biggest disparities, especially in aging, but also across the life course. To my understanding, this framework is really being used by NIH overall, and we're partnering with many different institutes and centers to be able to modify it for their different groups as well as disease states. So, of course, being a researcher, you're thinking, how can I contribute? How can I enact any kind of equity? This is a big issue. It's been going on longer than we've all been alive, and quite frankly, it will be here. We have to work towards creating equity. So we've seen research go through different ebbs and flows, say from the 1980s through 2000s. We want to describe, we want to understand what are the disparities. But then around 2000s to 2015 is people that are saying, what are the structures? What are the mechanisms? What is contributing to actual disparities? Now I'm saying that I think that we're in a third phase where we are creating equity, really, by evidence-based. What I mean by that is epidemiologic studies, as well as clinical trials, but also community-based strategies of how do we create equity. So just a note on how these things are different. So disparities and equity are not interchangeable. So this is published. I'm very open to speaking about any of my work, publications, grants afterward. I'll be around, but for the sake of the presentation, to put this here. The big part is that they are intertwined, but look at the last row over here. Disparities is thinking about identification and understanding, whereas equity and exclusion are thinking about solutions. How, in terms of the person, the community, as well as institutions, and the systems, may we build a different future for optimal health for everyone in society. So here are definitions here just for your record. I think Dan will supply this later. But if you look at the 2 definitions of equity, the biggest thing is fairness. Everyone being able to have a fair shot at optimal health throughout their life course, okay, and having the knowledge, the accessibility, as well as the treatments and research steps available to them to create this reality. So in my view, in my work, this begins with diverse lived experiences and diverse participant perspectives. So my work is all around social cognitive processes. That's really understanding how people view themselves and others, and that interplay within the key institutions that that I named earlier. Here particularly would be healthcare and research. So I'm coming in as a participant. What am I already thinking about research? What I know about research, is it accurate? And then how does that really play into my interactions, even potentially with researchers and healthcare providers? And you can use that journal template for any healthcare interaction, okay? And I typically do this through mixed methods research. I've been really outspoken on not using just quantitative or survey methods, but also bringing to fore qualitative in it. I'm dually trained in both, so it's really one of the most fun parts of my work is being able to design a study. Nevertheless, without inclusive research participation, without centering those lived experiences, we're not having a basic understanding of any disease state within diverse communities. What does that mean? We don't have a clear understanding of the issue, as well as we cannot create equitable solutions for everyone if we do not have those diverse lived experiences and those diverse participants within our research studies, all the way from qualitative to longitudinal to clinical trials and beyond. But also, we are not able to, we see this quite a bit in Alzheimer's, especially in our recent drug discoveries with aducanumab, with not being able to apply and generalize different pharmacologic solutions that we've come up with, simply because maybe 2% of the full clinical trial sample is anything but white men. So how does that work for the rest of the group that may be suffering from different disease states? But also everything from evidence-based practices and interventions, think of getting someone to eat as we eat more healthier, move more, to have more social activity. If we don't understand the context, where these social activities are occurring and how, what folks are eating and why, and their different sorts of physical activity, then we're falling short even at the intervention and education and outreach area. That's why I center our diverse perceptions and lived experiences. So recently we had a lead at the Rush Alzheimer's Disease Center. I am PI of what we call a core and a P30. And this is what we set forth after years of trying out different evidence-based sort of principles. How can we get these diverse perspectives, high fidelity, systematic, into our work? So I can say here the goal is really not only to understand and center, but also to partner. Really, that's the main goal, is to facilitate research being more engaged and more equipped to have stakeholder involvement, particularly participants. So if you'll join me in part 2, if we really have study participant voices heard, not just say once you've done the work, but once you're doing the work, when you're thinking about the work, having their voices heard to really do be. That's enabling participants to communicate. What do they want to see from research? It is publicly funded money. What are the outcomes that they would like to see in terms of the work that we do? And I do this with complementary qualitative and qualitative research. Really also facilitating not just the same group of people doing this work over and over, making sure that all of our scientists are able to have their work being participant-centric. That is the focus of our research by pilot plan as well, and now delving into the larger center. So this gives you a graphic of how I view this process of community members engaging actively in research. Being a community member is fine. That, you have to do no more than that, so I'm not setting that forth at all. But as we really say, once folks are in as research participants, invite them to be active. What do I mean by that? Suggesting it to their friends, speaking about it with their local media. Also being able to come move forward and say, hey, what do you think about our research agenda? Every year I host something with our center where we bring in folks to say, this is our research agenda, what are you thinking about it? And we break it down for them in layman's terms. Every grant that we present or submit, I have a lay summary there so that they may be able to look at my grant, see what I'm doing, and how it is really lending itself to the goals that we have for health equity for all. But then at some point, about 3 years ago, I began inviting people to say, will you start reviewing other folks' grants with me? So I am an NIH grant reviewer, of course. I got permission, able to say, can I share at least our significance there to say, what are we thinking? Is this something that will impact impact your community and planet. And ultimately, we haven't made it here yet, but a national infrastructure driver, meaning having those persons' voices everywhere. So it's something that I term a really envisioned view of research, and this should be coming out soon, actually, in a publication, is how we cultivate mutually beneficial and trusting relationships between lay communities and scientific communities to a dually relevant issue. So you can't research something that has no bearing on community lives and needs, and they have to have input on that as well. So it's very bi-directional, trusting and reciprocal. So something that a lot of us talk about is the centrality of trust. So before I go into define principles, throughout we have to have trust there. But really what I'm saying is the onus of trust needs to be on the institutions and the researchers. So we can't expect community members to simply trust us because we are MDs, PhDs, or whatever title that we may hold. We have to make the case. We are inviting them to this. They are living the experience, and quite frankly, they likely have a lot of resilience and coping mechanisms that we can systematically learn from and then scale up to the masses. And that's another aspect of my work that I do that I can talk about there. But making sure that everything is beneficial and reciprocal. The last question is one that I always use with training for new staff at faculty, is how do you become trustworthy, and how do you demonstrate trustworthiness? It's not simply saying I'm trustworthy, that doesn't necessarily work, but it's through years of showing, and it takes time. One way that I do that is by inviting participant voices into my work, not just say give me your advice, but to partner, but also give back. Every piece of paper, every grant that I have funded, I share with the community members in which I sample my work. So here, that was a big driving part in our previous grant, and the renewal that we just had recently, is 1 partnership, 2 parts, 5 guiding principles. And that's how I look at my work, that's how I conduct my research. The first is purpose. So for your research purpose, of course, that's natural for us to know what exactly are we looking to investigate and why, but even more so, what is your program of research aiming to show? But from the community piece, community involvement, knowledge, and experience, they have different experiences with your research purpose. They're living it every day. But also something that's more granular is what is their history with the institution? Something that we had to grapple with was, just because, say, participants or community members like me and other members of our faculty, they didn't necessarily vote well with our institution. And we had to know that. What was our institutional history with various communities around Chicagoland? But then also, what is the relationship with the research topic? From rural Americans to Black and African Americans to Latino, Hispanic, AAPI, we find in Alzheimer's disease, folks are very acquainted with Alzheimer's, but no one really wants to talk about it. Highly stigmatized and stressful. Knowing that background can be able to say, I can inform my research purpose a little bit better, and how do people cope with this already? What are their practices? What are their beliefs? But then also this goes into relevance. So you have to have the scientific relevance here. What does this study mean? Really, what are the implications if your study works out, expected and unexpected? Will it really move change for communities in which you're looking to serve and your research purpose? What is it really going to do in the grand scheme of things? But then also with community, is this issue on their radar? You know, are they aware that these things are going on? If so, why should they be aware? And it's up to us researchers to make that case. When I first started going out into the field, a lot of folks were very straight with me and said, well, there's nothing I can do about Alzheimer's or dementia. It's inevitable. It's just what's going to happen in older age. But the onus is on me now to provide information to communities about this is what Alzheimer's really is. This is what we can do in midlife. This is what we can even do early in life. This is the state of the science. You know, really being able to say and have a conversation about these are our thoughts. Also representation. This has been a sticky one, especially with the progress reports that we have with NIH, where we have to have various groups there. So when you're designing your work, thinking about Is equity or representation required or necessary, or are you truly equity-minded? Do you see this diversity in your participants being able to further your research purpose and its relevance throughout the community? But also, this is always important for a community, so it's no need to belabor that point. But also being careful of how you portray individuals in relation to disease states and other healthcare outcomes. And then fourth, I would say, researchers and community members, we have to decide where we're going now. What are we going to do? Separately, what are our roles and responsibilities? I did set forth the active research participation piece that was recently funded, but also really doing this together through research. Community members have different beliefs, practices, strategies that are working for them. How do we understand those, center those, and then leverage to create equity? And then lastly, I will then put a pin into resilience. Our community members are stressed. Obviously, we all are, even more so if you're dealing with a particular disease state, but they're enduring. So we need to be able to have a relationship between scientists and layperson to aid that endurance through research. And that will require us to be patient, really be able to say, this is what we're looking to find out, this is why it's important, can you join us? Being able to communicate that effectively, creatively, and flexibly. The big goal here that I found out without words during COVID-19 was being able to bridge and apply our work. So really thinking about research as scholarship, but also research as service. Okay? So now in my work and what I challenge others to do is to think of how can we convey effective information, prevention and treatment, but also how can we eradicate negative narratives, so speaking negatively about particular groups, so nomenclature is important. Also eradicate disparities, moving from explanation to equity, but really equity to encouragement and empowerment. So something we're seeing in our field is taking it from equality, where someone gets everything the same, equity, where you get what you need to address issues, but really going to justice, to address structures, systems in which this occurs. I think this is the next shift, but I still think we have a lot of work to do within the equity space, and I invite you to join me there. So I'm around for any questions and comments. I'm around for the rest of the week, Thursday and Friday, so I look forward to hearing from you all. And thank you for being an audience to my first in-person talk in over 2 years. Thank you.
What we're going to do at this point is we're going to watch a short video, and then I will invite our panelists up to the stage, and you will have more opportunities. You think about this is a lot to think about. Just some pertinent questions for our panelists. So we will start with a short video right now.
Hi, I'm Kayla Matthews. I'm Lyra and Braden's mom.
And I'm Brian Smith, and I'm Lyra and Braden's dad. Braden, he was the champ. He was fighting, like, cause we didn't, cause they didn't know anything what was going on with him, but he was, they were trying to get him to suck the bottom. Like, come on, champ. Like, that's his nickname, the champ. Yeah. So that's Braden. He was our champion. Like, he never quit.
Lyra, my papusi. That's what I call her, Lyra papusi. Ooh. That Lyra was the sweetest baby.
That's the sweetest baby ever. She was so sweet, like just
like porcelain skin.
I'm talking about the softest skin. I'm talking about just that's my favorite girl. Like,
man, it's so crazy because I felt like Braden was a mama's boy and like Lyra was she was a dad. She knew when he got off work. Like
when I got off work, she knew. She sleep all day. When I got off work, her eyes shoot straight open.
And when he leaving from work, wake up. I had to like touch her, hold her for her to stop crying. Like she knew he was leaving. And I was just like, y'all need to give me this type of, and I'll be with you all day. When she was first born, she spent from September to December in the hospital. And we had a lot of respiratory problems with her. She went from CPAP when she was first born to oxygen, and then she came off. Then she went to a ventilator. So then we was on the ventilator, I want to say like a month, and then she weaned off. But before then, they were talking about a trach, and we would need a trach for her to come home. So we went home on oxygen. So I said we stayed home all the way up until March, and then we got readmitted. She had RSV. You know how that goes with those kids. So we stayed in the hospital for a month again, went back home, We was doing good for a good little minute. Then she had got another cold, and oh, y'all, this was scary for us because at this point I really thought I was finna lose Lyra. So we drove to Birmingham. We was in the car, and she had a monitor that tracks her oxygen level. Her oxygen got all the way to 60. That point, I really thought she wasn't gonna make it because I had to do CPR in the car. So then she gets to the hospital, and they start doing, all the stuff they doing. Then they put her back on the trach, and then they flew her to Birmingham because we only made it to Shelby, I think, at that time. When we got there, she was back on the ventilator, and then she had RSV again. So we spent 7 months in the hospital. It was just a roller coaster. So she was on the trach the whole time there. Like, she was on the ventilator the whole time there. So they tried in October to wean her off. It wasn't working. So they took it out one time and she was doing okay. And then she coded. They had to re-intubate her. We was going back and forth with the doctor. So they was like, well, what if she can't get off the ventilator? What do y'all want to do? Well, at this time it was like, well, we don't want to trach. Not really understand, because really nobody really explained the trach. In my mind, I'm like, we don't want to trach. I don't know why we didn't want to trach at that time, but we didn't want one. So when they first brought it to us, we was like, well, we're just gonna see how it goes. And then when we seen that she really couldn't wean off the ventilator and like she really needed the ventilator, then it was like, well, okay, maybe we should do a trach. Then we had a meeting with pulmonary because that was who was on her case. So we had one doctor that was her physician when we left home because she left home on oxygen. He came to me, he was like, yeah, we have parents that are put on a waiting list for a trach. It could take a long period of time for you to do the training and all that. At that time, we was really just trying to get home because we understood like her prognosis. Like, we got her condition. And that was another thing too. I felt like they kept saying, okay, well, she gonna die anyway, so why y'all doing all this? That's the vibe that I had got. So it came to a point where like, they was like using reverse psychology, because like they would like say, well, maybe this is the decline of her condition, which was cool. I was like, okay, I understand what you're saying, but I still want to get her home. So what do we have to do to get her home? So he was just like, you'll have to go through a whole lot of training to do the trach and all this and that. And then at that time I was like, well, okay, well, we don't want to do that. So what's our next option? But we didn't have a next option because she couldn't go home on the CPAP because she needed more help to breathe on, like she couldn't do it on her own. So then that fast forward, then it was like, when they round, so then pulmonary came early and there was one doctor and that we had gotten to it. I ain't gonna lie. She was like, she not getting a trach. And I'm just like, who is you? And what's your place to tell me what my child can and can't get? It was like a lot of back and forth, like every doctor, because they change doctors every week. Every doctor saying, no, she's not getting a trach. Not really giving us a reason why, other than they kept saying she's at her decline. I was like, y'all making it worse because we just want to go home at this point, and you're just not giving a trach because y'all don't want to. That's not a good enough reason for me. If you're not paying for it, how are you to tell me that she can't have something that she needs? And nobody could really answer that question direct other than this the ending point. We just want to make her comfortable. So they didn't want to do the trach. So I was like, okay. So then one doctor came on, and this was my very first time seeing her. She asked me some questions and I was like, we need a trach. And she was like, okay, we can get one. I looked at her like I just seen God himself. I was like, where have you been the whole time I've been here? The next 2 days, she went in surgery for a trach and she came back out. Then we came into some more problems. So now we got the trach, but now I ain't got nobody to train me. So now I'm at a standstill again. So we got the trach, but don't nobody want to train me so I can go home with her with the trach. So that was a lot of back and forth too. Because I got close with a lot of like the respiratory doctors in there because that's mainly who was around the most other than the nurses. They even felt like they was doing us wrong. It got to a point where I was looking for a lawyer and everything. This can't really what go on in the medical field. How can a doctor deny a person something that they need? That was really blowing my mind. This is crazy. A doctor told me they didn't want to give Lyra a trach because they gave a family a trach before and that child ended up in a home because they didn't want to take care of them anymore. And I'm like, oh, so you want to use a situation that you did in the past, giving somebody something they needed and bring that to me like I'm that same person. How do you look at somebody and judge somebody off of that when you don't know them? If I'm up here every day, how can you base somebody's story off that? Yeah, they were short-staffed and they didn't really have nobody to train it, but we end up getting the training. It was a respiratory nurse that trained us. I'm really like cutting it short because we had went through hell to get the training. And then we had like one doctor, she really understood what we was going through and she really felt like we was getting mistreated. I don't get how one doctor came in and was like, oh, you can get a trait today. But all the other doctors were like, no, you can't get a trait. I had one come sit down and talk to me and was like, do you think this is what Lyra would want as end of life care? Like, do you really think a trach would be what's best for her? I don't know. It's almost like they was looking at her diagnosis as like, okay, when are y'all gonna pull the plug? Like, that's the vibe that we had got. Like, okay, you see she declining, so that should tell you something. And I'm like, no, that's not your call to make. For one, we never asked y'all to cure her, because that was another thing too. They kept making it seem like we was asking them for a cure, which we weren't. We was just asking to bring her home, because this is an hour and 30 minutes away from our home and her other family members that wanted to be around her. It was one time they had tried to pull the trach out again to see how she'll do. Because I felt like they did that to prove a point. At that point, I felt like he was playing with my child's life, because I didn't need a point proven. So they pulled the trach just to show that she couldn't do it without the trach, which we already knew that.
I think if doctors could push down that ego of I'm a doctor, I know everything. Cause that was the whole vibe. Like they was telling us they knew about Zellweger when we know that they didn't know about it. I feel like we knew more than what they knew. We know it's not a cure, but we don't know what might happen.
Yeah.
We got a
really,
miracle. You got children that did 5 years, and we can get 5.
We went through 1, 2, 3, 4, 5, about 6 doctors, like, and they changed every week. So I'm getting a new doctor every week. So that's, if I could say something to them, I'd be like, y'all either need to sit, all y'all at one time need to sit down with the parent and talk, because you saying you relaying this message through, like, there's just too much going on. I told them that too, because I'm like, at that point, if you got a patient like who's been there as long as we was there, all of us need to sit down and talk. Everybody that's on her case need to sit down and talk to me, because I need to understand where y'all getting y'all information from and how are you basing this off of this. So what was y'all reason for not wanting to give her the trach? And then the one doctor that did, what was your reason for giving it when all these other doctors were saying no? If I could tell the parents something, it'd be like, whatever the doctors tell you, just have more faith in your child and yourself. Like, cause at the end of the day, like, don't let them bully you into doing something. I felt like that's what they was trying to do. I ain't gonna lie, cause it came to one point and he was so mad at me. It came to one point, like, cause I was there so much that mentally I started to really believe what they were saying. And it was just like, I felt like I was being attacked. And I'm just like, but it's like, I don't know how to explain it.
It's like they really persuaded her, basically saying that it was over.
Yeah, like,
and then like, it was so crazy, like the next week,
oh yeah, she got to doing better.
She got to doing better like the next week. I mean, it was so hard, because, you got her in the hospital sitting all day.
It got to become a little draining, but then it was like he was at work, so he had to work, and I had to be up there because we needed somebody to be up there.
Peroxisomal family, like, we learned more information from you.
Yeah.
That led us to more information, than for real, like, you was a big help. They feel like we don't know what we talking about as parents. I argue with him because he said he knew about Zellweger, and I'm like, what you know? Tell me. I want to know what you know. He couldn't say nothing.
We know what you can read. We read that too.
And they was telling us about Zellweger, the stuff that we read, we read it 1,000,000 times. So I knew it by heart. At that time, I knew it by heart. So when they were saying it, I continued the story for them. I like, they were telling me about Zellweger, and I was reading it. Y'all just read it off the internet.
And then we young and we black. That's a reason why they didn't want to give her the trach too, because they felt like we was young. And I felt like it's because we was black. Because I was like, what's the reason here? They kept talking to us like we didn't know what we was talking about. And I'm like, we know more than y'all. If we wanted the ventilator, we would have had to pay for it out of pocket.
It was like $100,000. So I'm like,
okay, well, that's what we need.
If we need it, can we order it?
Yeah,
you
it
know,
got
because
to that
it
point.
got to that point. Like I had to, can we order it? Because we need it, obviously.
Yes,
Yeah,
and we
it
like,
was,
and then I was like, but why would we have to do all this if she got insurance?
Exactly.
So we was just like, at this point, we'll buy anything. We didn't care how much it cost. We just wanted her home. Because at this point, I didn't know what was y'all reason for telling us no, and we still don't have no reason for that. I felt like they knew they was wrong, and they knew they really had a lawsuit at a point in time. So then everything started to be like smooth. So like training.
The last 2-3 months, everyone felt where we was coming from.
Yeah, like
you can when we left that place, like it was quiet.
They knew it was some shady stuff going on, but like I don't know.
The respiratory nurses, they knew. Like we still talk to them.
We still talk to them to this day. Yeah, so they knew. So and it's so crazy. And then what was really making us mad, because we seen her decline in the hospital and we knew that. We was okay with that. We was just saying that we just wanted her home because we knew, because she stopped doing a lot of stuff. She stopped moving her arm. She stopped doing a lot of stuff, and we seen that. And I think the doctor seen that too, which was cool. We at least we know you know what you're doing. But we just wanted her home. That's all we kept telling them. We just want her to come home.
So to drive a quick point home before we bring our panel up, that story, as uncomfortable as it is not an anomaly. You know, this is a common story that we hear from our families. It is always exacerbated, and I think as Dr. Glover mentioned, you know, this is why it is so critical for our scientific and medical community to really find some common ground with our patients and their families. So, you know, we wanted to show that video, and it is tough to watch, but I hope that this drives home the point that the work we're doing in the scientific community, working with our families and getting as much data out as we possibly can, as you've seen the breakthroughs we've talked about today. This is challenging work, and we have a lot of work to do to embrace better equity, even in our rare disease space. So at this point, I want to bring up our panelists. Obviously, you have gotten to meet Dr. Glover, but and many of you heard today from our dear friend, Dr. Mousumi Bose, from Montclair State University and mother of Alon. But we also have Sika Dunyoh, who is with Travere Therapeutics, and she is on our diversity committee. We have a board-level committee committed to diversity. And we have board member Carolina Alfaro, who is also a parent and has been involved with the GFPD for some time. And Courtney Morrison, who is the mother of Jayla. And Jayla, you've got to meet as our patient ambassador. And Jayla's here, and Courtney's here with her mother, Vanessa. But I'd like to bring them to the stage, and then I'm going to turn it over to the illustrious Melissa Bryce, who will be moderating this panel.
Hi, good evening. I'm Mousumi Bose. I'm an associate professor at Montclair State University. I'm the mother of Alon, and this issue of diversity, equity, and inclusion in rare disease has been something that I've been really interested in, but I'm very new at. So I'm still learning, and I look forward to sharing some of the things that I learned from.
Hello everyone, I am Sika Dunyoh, and I work at Travere Therapeutics, where I am Director of Patient Advocacy. I work primarily on our rare liver and rare metabolic disease states, including peroxisomal disorders. In addition to my work in patient advocacy, I also do quite a bit of work on behalf of the company to drive health equity in rare diseases. In addition to my work at Travere, I am also a sister of a woman who had a rare disease, and she passed away in 2008.
Hi, my name is Courtney Morrison. I am the mother of Jayla Morrison, who's over there, who's the ambassador this year. She just turned 13 on Saturday. I'm pretty new to this whole movement of diversity. I'm just hoping to bring my personal experience being a single Black mom to a kid with a rare disease, and still learning and hopefully we can all learn together.
Good evening. I'm Carolina Alfaro. I am mother to Diego and Adrian Alfaro, who lost their battle to a peroxisomal biogenesis disorder. I welcome them to this space with me because it's been quite a few years that I've been in this space to see so many families and their children. So I'm inviting them to kind of be here and be present with me this evening. I serve as a board member now for the GFPD, and I'm also serving on the diversity committee. Outside of this, I do some diversity and equity work through my the college campus that I work at, which is California State University Stanislaus, and that's the central San Joaquin Valley of California.
I'm Crystal Glover. I'm also an assistant professor of neurological sciences and psychiatry and behavioral sciences at Rush Medical College, and I am equity through all of my research. Thank you.
Awesome. Thank you all for introducing yourselves. We're going to dive right in. As you may have heard today a little bit, our focus word for this year is our families. It's one of the GFPD's values, and we really have taken that to heart in our diversity work this year. And so, you know, I'd like to kind of think about what we just heard from Bryant and Kayla and think about barriers. What do we see as barriers to patients, to families, to our GFPD warriors, particularly with regard to cultural competency? And Carolina, I'd like to ask you to start that for us, if you would. And then also, you know, just as that relates to their experiences as patients and advocates and caregivers. So, Courtney, I think that's something that you and Mousumi and Sika could definitely weigh in on.
It seems like a simple answer, but it's not, right? It's one of those that takes time to process, and it's one that doesn't really have an answer for when we're thinking about, you know, how does it relate. But watching that video brought back, for me personally, so many memories about the inequities that existed for someone who had limited access to a children's hospital nearby. I had to go to San Francisco, and most of the time I had to get on a meta flight to get there. That was the closest one, and the reason for that is the only doctor in Northern California who had done research on Zellweger syndrome was from UCSF. So we were lucky in that sense. It was just by luck that we landed in his lab as patients. And I went in with zero understanding of what this was. And I thought about all the families and children around me. I thought about, if I'm having a difficult time as someone who's an English speaker, I can't even imagine the family right next to me sharing the same room who doesn't understand the language. And the language, the medical terminology was very hard for me to try to understand. I witnessed there that there was a lot of cultural incompetency happening in the medical field or in the hospitals that I was visiting. And what I mean by that is I would notice how practitioners made assumptions about the families of color next to me. There were simple assumptions, like even myself personally was, oh, let me go get you somebody that speaks Spanish without even asking me first if I spoke English, right? Or let me go get somebody that can come pray with you, right? Because you must be Catholic, I'm sure you want a priest. And so those simple assumptions made me realize how incompetent our practitioners was. I went back home, I studied some stuff, I was reading through materials, and I was like, you know, it's interesting because you know, here I work in higher education and I promote so much the importance of getting your degree, right? And getting, you know, most of the students that come in, they either, and at least to our campus, they want to either be doctors, lawyers, nurses, right? So they can go through an entire undergraduate degree without having to take one course on cultural competency or understanding culture. They can go to get a master's and a PhD without having it to be a requirement for them to take a course on race, on culture, on power, privilege, all of that, right? And so what we do is we set up ourselves to be in situations where we're now making assumptions or not understanding a lot of the barriers that exist. And so I like to look at it through a lens of cultural humility now, where I've studied some folks that have talked about how we can come in with a humble approach, a genuine approach to understand patients and patient care. And how do we think about elevating and holding ourselves accountable for that learning and having that genuine interest to just ask, to invite community. So Dr. Glover, I just want to acknowledge the work that you're doing to center the voice of communities within research, within practices. Because of that, it's not just a one-time thing where you're checking the box, right? It's inviting the community, centering those voices, and having a better understanding of it all. So as a parent, you know, it's sad that I had to witness so many things that I felt, you know, and I probably can go on for, I mean, how much time do you all have? Because I have I'll be here all week, right? Talking about another question, but I have so many different stories that I think relate to everyone that's here in that room. And I just hope and invite you all to take some time, if you haven't done so already, to really take these conversations seriously and bring them back to your spaces and write, you know, grants or policies or anything with good intention. So thank you.
So I wonder, I'm sorry, that was loud. I wonder if Courtney or Mousumi would like to respond to what Carolina said, just in terms of, you know, assumptions.
I can talk about when Jayla was first diagnosed. I had her when I was 20. So going into a doctor's office, well, first of all, she got diagnosed when she was in the NICU. Also by luck and chance that there would happen to be a neurologist that knew about the disorder. And we also had to travel to a children's hospital because there wasn't one close to us. Now there is one in the city, thankfully. But we had to travel to actually get that diagnosis. And I remember when we went, they were talking to us and telling us all these big words. I was in school to become a music teacher, so I barely did any science in college. I didn't know anything that they were telling us, but they also told us don't go home and look it up because they didn't want us to know what could possibly. Don't Google it because they didn't. I guess they didn't want us to freak out, but also I think it was important that we went home because they threw words at us that we didn't understand. I related so much to Kayla and Brian's story just because I think they're around the same age as me. I was young and I barely knew how to advocate for myself, so now I had to come in and try to tell these doctors that this is what I need done for my daughter. Learning that has been difficult. Now I'm sitting here in a panel and it's insane to me doing all these interviews and things like that. But That has been the biggest thing, is learning how to be an advocate, and how do you even teach somebody how to do that? And I think those type of things should be set up in place of, okay, this is what you're going to be having to deal with. How do you get there to get what you need and want for your child? I think that's what I got from that whole video, and what I wanted to add.
So I think everything that both Carolina and Courtney have discussed are things that I've experienced. It's been a long time since I've had to deal with medical care for my son. But when I reflect back on that and I listen to Kayla and Brian's story, there's a couple of things that I think about. One is that there's a lot of things that were very similar in sort of our interactions with doctors, and that there were a lot of things that were very different from my experience and what Kayla's experience was. And I think that that's really important in sort of remembering, as both practitioners in the field and as families that are dealing with this disease, that just because you did or did not experience something, it doesn't mean that that's exactly what, or I'm sorry, just because you experience something doesn't mean that's exactly what somebody else experiences. And we have to recognize that, you know, different people have different experiences with receiving medical care, with clinical trial participation, and we have to respect sort of what people's decisions are in making these, you know, making these decisions for their child and for in terms of participating in research. The other thing that I thought about when I was listening to Kayla and Bryce's story, and it sort of, a lot of it was cemented in with what all the really insightful things that Dr. Glover was talking about, has to do with, this is, I think Kayla's and Brian's experience there's a lot of discussion with respect to intersectionality there. Not necessarily, I mean, certainly intersectionality with respect to identity, but intersectionality in terms of like the disparities that we're sort of, that we see here, you know, because it's not just that they were Black, it's not just that they were young, although all of that I feel like plays a very important part in, you know, how their interactions with their medical care providers have. But it was also because they had this diagnosis. And I think when we put all of that together, having this diagnosis that most people tell you they're probably not going to live that long, why should we intervene? And then add on top of that, you know, the sort of expectations, well, these kids are young, maybe they probably don't know that much, let me teach them about what they're supposed to do. It creates a very uncomfortable place, you know, and that I think we need to really like start to recognize that this intersectionality has a deep impact on the care that we receive as families.
So Sika, that's such a good point. Sika, I'd like you to comment on that, and especially as it relates to your role as a caregiver for your sister, your experience as an extended family member, and then, you know, what can we do? You're from Travere. What can we do to partner with academia and industry to address this?
When I was triggered hearing their story, and went back to 2018 when my father was sick and in his last days, and some of the conversations I was having with his healthcare team to try and advocate for him to get, what I thought was right for him at the time, and getting a lot of pushback. And when you are in, I just spoke to Mousumi earlier, and we were talking about, when you're in these situations, it's hard to tell whether the pushback or the treatment you're getting is because you look a certain way, or if it's because, you come off a certain way, or if this is how they treat everyone, right? And so you question, yourself sometimes, and I think at the end of the day, something that Courtney said is really important is self-advocacy. And I think it's oftentimes very difficult when you're in a healthcare environment to advocate for yourself, especially when you feel that the people around you are somehow more educated or know better than you, but I think it's extremely important to learn self-advocacy or to walk into healthcare settings with an advocate, someone who can speak up for you if you can't. And so this is something that I think is important across the rare disease community, and I think it's going to be something that helps bring more equity to everyone navigating the healthcare system in the rare disease space. It is also something that we have been talking quite a bit about in the Rare Disease Diversity Coalition, which is an initiative that is really working to drive evidence-based solutions for people of color with rare diseases. And it's trying to bring together stakeholders across the ecosystem, so providers, industry, patients and caregivers, government, it's like another one, government. And so really the goal is to look at all of the places and spaces where patients of color are going to be meeting obstacles, and how do we look at those obstacles and find solutions that will allow these families to overcome them. And one area is looking at self-advocacy, and how do we not only look at the system itself, but empower patients to speak up for themselves, empower patients to know how to file a complaint when they need to. And I think that this is something patient advocacy groups like the GFPD can help provide that training, so that families, when they're newly diagnosed, know how to be savvy when they're navigating the system.
That's such a good point, that empowerment. And it brought me back to something Dr. Glover said, and one of the themes of your talk was building that around communities. So, given the issues that we've spoken about just in the last few minutes, what do you see? How can groups like ours really help empower people to self-advocate? What do you think we should be focusing on, and where do you see the future of that?
I think that's a great question, and really drawing from my work that I do in aging and dementia, is being able to, I always view building knowledge and skills of the community as truly enacting health anyway. Because the more people are informed about what's going on or what they're going through, it's easier to self-advocate. You know what you're asking for. You know if something is where, okay, I may be treated in a disparate manner, or this is just par for the course, so to speak. And you also know what should I be asking for. So I believe the biggest thing to really look into is to partner with major groups, and we have quite a few of those that are training community members on how to be able to not only advocate for yourself, but understand the implications of various disease states, but also not just while the disease is here, but as the grieving process, because that's huge in our world in terms of dementia. We're usually working with, of course, the person living with dementia, but really focused on their loved ones, their caregivers, that are left here at the end and having to do all the advocating. So at one point, a person with dementia cannot advocate for themselves. So that's left to their caregiver. So making sure it's not just a community initiative, but a family and wraparound. And the first place is really to disseminate what you've already learned, making sure that it's layperson friendly, make sure they know why it's important, but then also in continuing to go back. You can't just do it one time. You have to be able to reiterate, this is what we're learning, this is the state of the science, and then these are your care options, and this is what it looks like. And having that on a regular basis is what I can really suggest there. And focus on the person, of course, with the rare disease, but very much so the caregiver. That wraparound service is beyond important.
That's such a good point, and I think, that is why we really wanted our scientific attendees to hear so much of this conversation tonight. And, I'm just thinking back to our families, and this idea that you brought up, Dr. Glover, about trustworthiness, having providers become trustworthy and worthy of trust. You know, we talked a little bit about that, but Carolina, Mousumi, Courtney, love to hear your perspective on that. Do you, you know, as we're talking about providers, do you feel like you had that kind of experience? Do you feel like you were able to trust your providers? Do you feel like they were worthy of your trust?
Some, some not so much. I think, you know, again, going back to what Dr. Glover was saying about the sort of, I think the model that she sort of presented is that there are things that you could do on the individual level, like talking, you know, self-advocating, but there's also stuff that we have to recognize that is on a systemic level are things that really, really need to change. We need more diverse medical care providers. We need more medical care providers that are culturally competent and are aware of the different sort of familial structures that are present in different communities of color and other just overall diverse communities. So that is, I feel like that sort of education is really on the medical care providers to be aware of that, and I'm not necessarily saying that like doctors should come out and be like, I've done this, 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 and you should trust me because of that. But I think having that education will allow them to approach families in a manner that is approachable. And I can't think of a better word right now, but in a way that they can really foster trust. And another thing that we heard from Kayla and Bryant, and that I hear for a lot of families is sort of going into, and somebody else said this here too, is really going, as providers, I think going into a situation with some semblance of humility is really, really important because the truth of the matter is these are rare diseases and nobody knows everything about them, you know, unless you've been doing this since, you know, day one. And so going into, and I've heard this in some of my family focus groups, is that, you know, where families have said, you know, I really like the provider that comes in and says, I don't know everything. You know, let's work together and try to figure out what's the best way to provide care. And this is not just looking at, you know, inclusion, you know, from like a cultural or racial or, you know, whatever perspective. It's just all across the board. Just maintaining that sort of humility, giving caregivers the respect that they deserve, you know, for being caregivers and learning all they did in the care of their child and working together in sort of figuring out what care means for their child individually.
Yeah, I know you didn't want me. I'm just wondering, you know, if Carolina's doctor thought that he or she was culturally competent because he knew that she might be Catholic, or because he looked at her and assumed she probably only speaks Spanish, right? And so, to your point about humility, I think it's important that you know, there's an understanding that doctors should approach patients without assumptions, right? And come willing to listen and learn. And I think that is what's more important than being culturally competent, because I think there can be some very flagrant assumptions made that may offend families. You know, no community is a monolith, and I think it's problematic if you approach communities assuming that you know them because you know have learned stereotypes that are not accurate. I oftentimes talk about the fact that my parents are West African, and so there is a different relationship that West Africans have to the medical community, which is reverence, right? And so the concept of mistrust is not relevant to, you know, actually it's you're gonna see the opposite issue, which is I don't question the doctor about anything, whatever the doctor says goes, and so that leads to other types of health disparities. But I think it's important that doctors really embrace humility and just embrace the willingness to listen and learn.
That's such good stuff. Go ahead, Dr.
You struck a nerve there, with, I am a long distance caregiver for my dad who has end stage renal disease. So being able to converse with his healthcare team, I find myself training them with saying, the simple thing is just ask. You don't have to make assumptions. You don't have to tout, say, your cultural competence training. How about just asking? And that's what we oftentimes teach when we do give our cultural competence training at my medical center is, we all show up with implicit biases because we all live in the same society. Whether it's me or Dan or anyone on this panel, we're operating under this system, and these things have seeped into our thoughts. However, you are responsible for equitable health care, and at the most, or at the least rather, is just ask, because we don't know, or you don't know. So I definitely agree with everything y'all said.
And that's what builds trust, right? Is just that informal conversation, that side conversation with that humble approach. I think that for me was huge, having those side conversations. And half and half, right? Not everybody, but just, you at least from my experience, again, it was just, 50-50 chance, but.
So this is maybe a good segue to something that I've been thinking a lot about lately, justice and historically excluded populations, and just, how can we adopt a model that includes justice, equity, diversity, and inclusion, and how can scientists in the scientific community help with that? I guess I'm at the age where I'm just flabbergasted by the lack of justice in the world, perhaps. I don't know. But this is just, or maybe it's just a season of life I'm in right now. I don't know. I'd love to hear the panel's thoughts on that.
I'll let the actual scientists
There you go. You're an actual scientist.
So I really feel like work that like what Dr. Glover has done is really important, sort of like as a sort of overall kind of better understanding of the state of healthcare and how equity and inclusion and justice is sort of sort of baked into policies that we have in healthcare or how it should be baked into policy. Sorry, I should have rephrased that. I think what I would really like to see is, sort of moving that sort of thought, that sort of thought process to find out where, there are issues with respect to diversity, equity, and inclusion within the rare disease space in particular. And one of the things that I've been working on for a little bit, and definitely in the early stages, is trying to identify what are the different sort of outcomes where we feel like there are disparities in healthcare within the rare disease space. And there are things that I've sort of looked at in the research, and then there's sort of like anecdotal experiences that I've either experienced myself or we've seen with our families, and a lot of it, and so what I've been sort of focusing on right now is racial disparities, but I know that it's so much bigger than that. But we are seeing disparities with respect to diagnosis. We are seeing disparities with respect to clinical care that's provided, and then that has an impact on overall clinical outcomes, and that is oftentimes influenced by patient-provider relations. And then the thing that is sort of like a sticking point with me is I feel like these types of preconceived notions, biases, whatever, is really is something that you see in particular in the rare disease space in coordinating things like end of life care. And when you're there, when you're sort of coordinating end of life care, you don't even, and I think Sika sort of spoke to this, is you don't even notice that this is happening that this is sort of, this bias is sort of seeping into the decisions that you're having to make. The hardest decisions that you're having to make for your loved one. And so I think the first step here, and it's a small step, but it's still an important step, is basically identifying where are the big sort of issues where we see these disparities occur. And then once we can identify where those specific problems are, then we can start looking at what other other groups, outside of the rare disease space have done to try to address those problems, and use that as sort of templates to try to make these situations a little bit better. But first, we have to acknowledge that these problems happen in a very specific way before we can intervene. The end.
There you go. Anyone else like to comment? Carolina, I know you do. Go ahead.
End of life care, there's also the afterlife care, right? So I was thinking about all the injustices and inequities that exist for those families that are going through that. And some thoughts came to my mind. I was thinking about how it was not even 12 hours and I already had people knocking at my door ready to pick up medical equipment. And there was no, oh, I'm sorry for your loss. It was, we're here to pick it up and we got to take it back, we're loading it up in the van, right? So think about the impact, that it has when you don't work through that justice lens. And it's so important to think about that and the intersections that these families have. So you might have a family who has various identities and various ways of addressing a situation or a loss. And so it's just important for us, as we are embarking in changing the narrative of justice work or equity and equality and justice, that we really think about those families that are affected and impacted. I often like to look through the lens of social justice because it's removing all barriers. Yes, we're figuring out the structures, but we're working through a lens of how do we not even think about a barrier in the first place? Let's look at the options, let's look at the opportunities, let's look at the ways at which our families and children don't have to struggle in these hospitals, in these spaces. So how do we work through that lens? It's a loaded question. And it's not one, again, that we can, come up with an answer for. But I think that collectively we have a more powerful voice to be able to say, we're all working towards this together, and perhaps we'll see some more generated outcomes at the next conference, right, where we start to see some or hear about some of the work that is being done to address that.
So, as you all have been talking, I'm like, that's another problem we have to solve. We have to solve that problem. We have to solve that problem. And Sika, I'm wondering if you could share just a little bit about the Rare Disease Diversity Coalition and the idea of convening multiple groups that are all working on something very targeted. Because, I would love for our organization to do all the things and to fix all the things, but every organization has to focus on something, and we can kind of only do one or two things well. So could you share a little bit about that?
Yeah, I'm happy to. So we are the founding sponsor of the Rare Disease Diversity Coalition. It's led by Black Women's Health Imperative. And essentially, the concept is this work can't be done alone, right? It's gonna take everyone, it's gonna take multiple stakeholders. We know that health inequities have happened for centuries in this country, and so it's going to take as many people as possible to topple the issue. So the coalition really brings all of these stakeholders together and is doing the work across different working groups. And each working group is looking at various aspects of the rare disease patient experience. And so there's a working group that's looking at research and clinical trials, and is looking at ways to help diversify PIs that are doing research in clinical trials, which is really important. There are not enough PIs of color really working to do research in the rare disease space. So that's one program that group is doing. There's a group on, looking at diagnosis and treatment. One example of a project they're spearheading is knowing your family history. So a lot of, I don't remember, I think it was you who said that, a lot of communities of color don't talk about the health issues in their family. There's just so much stigma around, disease, right? And so it's not often talked about, and so the focus of this health campaign is to really encourage families to talk about their health history, right? There's another working group, a provider working group, which I've been most active in, and so we're really working to look at how do we diversify the healthcare space. And so one initiative that we have is a fellowship program that's specifically for communities of color to work in the rare disease space, learn about rare diseases. Hopefully we convert some of them to be future doctors and nurses and other allied health professionals working in the rare disease space. And then the other two groups are patients and patient advocacy. So how can patient advocacy groups like the GFPD be a more welcoming home to communities of color? And really also a lot of the conversation we just had about self-advocacy and how to be a savvy patient. And then the final one is government and policy. So all of these groups are really busy kind of looking at how do we enact meaningful programs to drive progress. And you're all welcome to get involved, like I said, the more the merrier, but really the focus is, where are the issues, and let's look at solutions, because we already know what the issues are. When we started this work, we were like, we are not going to sit here for 6 months and talk about what the issues are, because we already know what they are. Let's figure out some solutions, and let's, get them going as soon as possible. So I think it's a really important initiative. I have not seen, anything else like it in the rare disease space. I really believe in the potential that it has to impact a lot of people. But in addition to the RDDC, I think that the work that individual companies and organizations and healthcare systems are doing are equally as important. I think that everyone needs to look at themselves and look at how can we improve, and our company is doing the same. So so thanks for letting me talk a little bit about the RDDC. Yeah.
Just to sort of give a specific example of some of the things that the RDDC is doing. I'm serving on a grant that was funded by the patient caregiver advocacy group, and what they're doing right now is actually sending out a survey to patient advocacy groups to sort of really take their temperature on where they are at with respect to their DEI type initiatives and whether or not they think about that. And I totally agree that we need to get more solution based than problem based, but really trying to understand where the sort of intervening points occur with these different advocacy groups, regardless of how small or big they are, I think is a really important first step in trying to figure out what's the best way to cultivate the best types of solutions for different patient advocacy groups. So that's one thing that they're doing right now in real time, is really trying to address what are the needs of different advocacy groups to best sort of incorporate and bake in these principles into their mission.
That's awesome, thank you. And I'd love to let Courtney kind of close us out here. we are a patient advocacy group, the GFPD. And Carolina, you can comment and everyone can comment, but this is really directed to Courtney. You know, I would love for you just to share your experience. We're gonna run over because this is important, I think. As a member of our patient advocacy group, what would you share with the folks that are in the room here today about what that, you know, being a part of the GFPD group has been for you, each of you, Carolina, Courtney, Mousumi.
We were talking about before the relationships that I've had with Jayla's doctors, and some of them have been positive and some of them have been, you know, negative. But I will say that it's been funny that I will go to the doctor and they'll ask me, have you talked to the other parents? Because they don't know what to do, right? So the being a part of this community has helped us figure out, okay, so if this doctor doesn't know, maybe we need to travel to go to a different doctor, right? But not everybody has the access or the money to do that. So I think it's important that we continue to reach out to different families and that they know that the GFPD is here. I actually just met a family today from Colorado, and it's wild that I never knew them, but I was there. Sorry, I forgot what else you asked me. What else did you ask me?
Yeah, and I think,
experience.
yeah, and I think, you know, what would be your hope for our organization? You know, when you came 11 years ago, when we started the GFPD 11 years ago.
Yeah, so.
What's your, is it 12? I don't know.
Yeah, I think we got involved in 2011. I think so. We've been here for quite a long time. I remember when we came in and nobody looked like us. So I was kind of nervous, and also I was the young parent as well. So didn't know what to expect, and that's kind of why when you guys asked me to bring Jayla in as the ambassador, I wanted people to see her. When you go to the website, there's really not a lot of people that look like us, and I think showing, you know, Kayla and Ryan's video as well, it helps that there are people from different areas of life. Just because, you know, both of us are Black, I didn't have the same issues that they had as well. And I think that is the important part of it all, is having the representation present at all times.
I'll just echo that representation does matter. GFPD has been the #1 support system for families like us. I was part of pre-GFPD, so I was, you know, coming to these spaces separate, you know, desperately trying just to find a family that resembled my experience, and so I'm so grateful for the relationship building that has happened, not just with the families, but with the children. Even though they can't talk to us, right? They talk to us with their eyes, with their expressions. And that right there has made community within our families. I also think about the scientists and the doctors we've met along the way, those that have been here since the beginning. That's family to us. And when we do go back to our spaces and talk to other practitioners and doctors, we feel more comfortable doing so, knowing that we have the support of the doctor, the medical team that supports GFPD. So I want to thank everybody here that's here for us, for families like us. Even though I don't have my voice anymore, I'm just really passionate about just trying to find solutions for these children and these families. And I just want to say thank you to everybody here that's taking time out of your day to listen to these stories and to be part of this journey.
So I think that's actually a great way to maybe close. And unless there are questions from anyone in the audience, any comments? Ray in the back.
Yeah. Do you mind if I ask a question?
Yeah, you can ask a question.
Okay. So I'm a member of the LGBT community, and today Joe Biden signed oh man, what's the word I'm looking for? Executive order declaring that the LGBT community can now adopt people. Right? Adopt people. My question, I heard the two young couple talking in the video about somebody that needed to give up their child, or a doctor had said previously they had given up their child had this disorder and similar. So in approaching somebody who's adopting, so especially like the LGBT family that's dealing with a lot of that kind of stuff on the side before roommates, and they're just coming into this life to try and provide medical care and all of that. I would just say, like, I was not adopted, but I also my family deal with like whether they would adopt or not, and my sister has always wanted to adopt those with medical conditions. And I myself do not want a family like children, but I want to invest and help others who are fighting to raise those that are going to lead us and be our future, right? No matter what kind of conditions, what look they have, what style, any of that kind of stuff. So in thinking about your diversity going forward, what kind of resources, do you provide any resources for those who are trying to just specifically adopt? So like, you can't look into their family history, like, because their parents are either out of half or that kind of stuff. So do y'all have any kind of specific resources to help adopting families?
So that's such a good question, and since this is a genetic disease, we help families build their families in many different ways through a variety of options. Mostly, would you like to take this for a second?
So, are you talking about adopting kids that have these medical conditions?
Specifically, yes.
So, as far as I know, that this is actually a relatively new conversation for us, at least within the ZSD space. I do know of other rare disease groups where where caregivers have adopted children, like they didn't give birth to children, but they're taking care of them.
Right.
And what I've seen in that community, and I would expect if that were ever the case in the GFPD community, is that we embrace families, that are taking care of our kids, no matter whether or not they are their biological parent. Right. And I would expect that we would do the same. And if there were specific situations to address their sort of needs in the process of adoption or after that, the GFPD would, and I'm sorry, Melissa, I'm speaking for you, but that the GFPD would do everything in their power to try to facilitate that in the best way possible. I don't know explicitly what those issues are right off the top of my head, but I think the mission of the GFPD is to help families that are affected by a peroxisomal disorder, regardless of whether or not they biologically gave birth. So I would think, and Melissa, you can speak to this, that this would be if we were put in this situation, that we would do everything within our power to try to help this whatever family is going through this process.
Yeah, I know the two big things that they're going to face is the fact that they aren't biological and just the history of the family and the medical care and stuff. Whether the government will provide medical care like they do for other families that aren't LGBT. So there's kind of some of that stuff is still up in the air. So that's kind of what I was asking. I have a lot of friends that are gay, lesbian, trans, and they want to adopt specifically kids who can't take care of themselves or won't be able to take care of themselves in the future or any of those kind of things, any kind of genetic issues or CF. A lot of kids with CF being adopted by a lot of my friends, and they're looking at that as well. So it's like
I would expect from in terms of the people that are responsible for coordinating the adoption, Regardless of all the progress that we've made, there will still be challenges in terms of determining the suitability of parents and if their LGBTQ status would. I don't think it should play a role, but I would bet that it would be something that they would have to sort of like address. And these are certainly initiatives I'm hoping that as we move forward, we spend a lot of time talking about race, and it's obviously something that's very in culture, and that's very important, but we do have to recognize that there are challenges in all across the board in these diverse groups, whether it be based on race, culture, or sexual identity or orientation. So and I would expect that, as we become more, as these sort of issues sort of become more things that are coming to light, that we would figure out ways to come up with solutions to help these families in the best way that we could.
Thank you so much. Thank you so much.
Awesome. What else? Yeah. Oh, I see you. Vanessa. Here. Just talk loud, Vanessa. You know you can.
Hey.
Love.
So I'm Courtney's mother and Jayla's grandmother. I'm happy to work in HR, so I know that DEI is a topic of conversation in every organization. And I would just ask the medical professionals here that when you're invited to those conversations, that you remember that what you heard today affects people's lives. It's not just a class that you've been asked to take or a box that you have to check off for the year, but just to keep in mind that this does really affect clients, your patients, and families.
Awesome. Thank you, Vanessa. So you didn't need a mic. Anybody else? I do too. Thank you all for being here tonight.